Now it's my great pleasure to introduce Dr. Patricia Robertson, who is a legend among physicians in the field of obstetrics and gynecology, and specifically lesbian health. She's been working on this issue since 1980 and is active caring for patients as a researcher and also as an educator, the author of the first ever book for physicians about Lesbian Health 101. So please welcome Dr. Robertson.
Well, I am beyond thrilled to be here. Grassroots is where my heart is, and all of you are going to make a huge difference to your patients and as they come to your clinics and to you and as you provide nursing. And I did ship 400 books down for you. They're in the registration area that you can take back to your clinic on lesbian, bisexual women's health. Great. So I'm going to kind of go through the lesbian kind of life cycle and bisexual women, and also to say that there are more bisexual people than there are under any other group in the rainbow, okay? There are more bisexual people than lesbians, than gay men, than trans people, and they've been totally neglected. One of the studies we're going to look at is by Audrey Coe in San Francisco, and she found that bisexual women's health is actually worse than lesbian health in terms of disparities. So please come away from the conference with recognizing that this is an area that really needs to be addressed. So about 1 to 5% of the female population is lesbian or bisexual, but it varies. And Lisa Diamond did some very important research to show how it varies over the lifespan. It's always hard to define lesbians because you either have self-identified lesbians. However, of that group, 30% are having sex with men, but they consider themselves lesbian. And then from the AIDS epidemic, we learned about behavior, that's often different from identity. And unfortunately, the research in lesbian, bisexual women's health is all mixed. And so each study may have a different definition. But we'll go over some of the important findings. Lesbians are very diverse ethnically. And as we heard about the triple threat earlier, women of ethnic minorities in our country are part of the triple threat in terms of coming out. So many more of them are actually closeted and not open about their sexuality. Lesbians are all ages. The average age of a lesbian coming out may be around 16 and then to older age, whereas often gay men know earlier that they're attracted to men. All educational levels, incomes, and locations. More lesbians are in urban areas, but there's certainly a lot of rural lesbians also who have a lot of health disparities. And this is some of the research Audrey Coe did showing that there's delayed health screening in women who are bisexual, as well as poor mental health. And there's now, it's always hard to find control groups to study interventions, but people have started using sisters of lesbians who are heterosexual as a control group in some of the research because they were raised in the same environment, similar genetically, to look at differences. And for bisexual women, they have poorer mental health in general than their heterosexual sisters. So we're going to start with lesbian youth. And Lisa Diamond did some really important research and looking at 79 sexual minority youth. She followed for 10 years, and 67% had changed their identity. And of course, youth today don't like categories. So it's really important when you do your clinic forms, you can put down how do you identify, but always leave a blank. And you'll be so surprised as to what gets written in there. By curious, exploring, and at least you know you want to be really open and inclusive in your language in addressing this. The majority of lesbians don't disclose, but they want you to know they're lesbians. So that's kind of put you in a quandary. How is your gaydar? And it's probably not totally accurate. It used to be easier. We had Birkenstocks and plaid shirts, but now we have lipstick lesbians, and we have, corporate presidents, environmental services, and you just need to not assume anything. That's the important message here. Just don't be heterosexist and assume everybody's heterosexual. And we've been teaching medical students for years on how to say, are you sexually active with women, men, neither, or both? And when I started asking this right out of residency, and that's been a long time ago, I was always a little anxious, but in fact, it opened up so much communication for me as a physician with my patients because most of my patients are heterosexual, but they'll open up about things like shooting up in college and worried about Hep C and things like that because they know I'm inclusive and they know I'm interested in them as individuals. So that personal communication and that relationship you build is really critical. And having inclusive forms, I hope you all go back and look at your clinic forms, and you've got some great examples in your folder about how to ask these questions. And especially when my patients go into the hospital, it's really important that I know who their family is, because there have been terrible cases of LGBT people being separated from their families. There was a lesbian couple who had 3 adopted children who were leaving Jacksonville, Florida for a cruise, and one of the women had a seizure. Was taken to the hospital, Jackson Memorial, and her partner was denied being able to be with her as she lay dying, despite the fact she was faxing all over the country and couldn't get the forms. They said, oh, this isn't California. We don't allow non-related people to be together in medical situations. Finally, she was able to spend the last half hour with her partner. But only with Obama's executive order have LGBT people been able to get into ICUs and be with their partners as they die. It's pretty shocking. And there are some steps, but you as a provider can really be helpful, because one of the deficiencies is that very few LGBT people, and people anyway, have power of attorneys, have living wills. This is something we all should have so that our loved ones know what we want as we are end of life. And you never know when that is. Of course, the young people feel immortal, and I can't get my own kids to be transplant donors yet. But we all need to work on this. So the questions I want to focus on today is acceptance. And Caitlin Ryan did some amazing research about the Family Acceptance Project. Have any of you heard about this? So she's in Northern California, and to me, it's one of the most important pieces of literature in the medical literature since HIV/AIDS, and that is she correlated outcomes of homelessness, depression, suicide in LGBT people and looked at association with whether their family was welcoming or rejecting when they came out. And there was a high correlation. And what she does is she works with Mormon families, other families of strong ethnic backgrounds who are very disapproving in terms of using the right language to communicate with their young person as they come out, so they don't get alienated from the family, because we know that there's a much higher risk of those young people, especially, having poor health outcomes. I also want to address the fact that control of pregnancy is an important issue for lesbians also, and then the whole issue with lesbians and breast cancer. So, mental health issues. I'm not a psychiatrist, but I spend the majority of my day as a counselor, actually. My physical exam has gotten very short with all the technology we use in obstetrics with ultrasounds and things like that. But just talking with patients is so, so important. And yet, as a physician, I have about 10 minutes per patient. And so I really rely on my team to really finish that robust evaluation. My nurse, my front desk people. I recently had my first trans man pregnant patient, so I was trying to do it all myself, which was impossible, to try to prepare everyone that our medical record system, the electronic medical record system, would not recognize his name. Okay, it kept coming up as his previous name, and he, he's a he, but the female name is with him, and to try to really respect that was important. And his story is very interesting because he had started testosterone about 4 years ago and was told that he couldn't get pregnant, was with a male partner, had a 20-pound weight gain, went to a clinic. They said, oh, you have an ovarian cyst. He finally went to Planned Parenthood, and he was 30 weeks pregnant. And so it was really a shock for everyone, but really they did amazingly well and had a wonderful baby and have adjusted quite well as a family. But again, the miscommunication about the fact that trans men do get pregnant on testosterone has not been out there in the community. He now has an IUD. Okay, so anyway, going back to mental health issues, depression is definitely increased in lesbians, and Vicki Mays did really important research at UCLA to show that this is really homophobia. It's the daily experience of oppression in our society for being different. It's really important that it get diagnosed. Lesbians are more likely to want to use therapists than antidepressants, but and there are some groups like cognitive behavioral therapy that hopefully are lesbian oriented, but that's also always a problem for lesbians is like going into recovery for alcohol and having small groups, and they have to come out again in front of people who are judgmental, and then how can they really be themselves and be able to focus on treatment. And here's Caitlin's acceptance project with the statistics. So with family support, the depression rate was only 22% versus 63.5% without it. Substance problems were much higher, and unprotected sex was much higher. And these are examples of rejecting behaviors by families. These are usually with teens. Banning and removing any LGBT decorations in her room, telling her, oh, you're going to grow out of it. I can't tell you how many of my patients told their mothers they were a lesbian, and the mothers just didn't hear it, couldn't hear it, and then asked 5 years later, are you still a lesbian, or who's your boyfriend now? Asking them to keep their identity a secret, banning her friends from the house, telling her she's doomed, and excluding her and, of course, her partners from family events. As opposed to the flip side, the accepting behaviors, allowing her to decorate her room and talking about, her disclosure and being affectionate to her as a parent, advocating for her at school when she's bullied, welcoming her friends, connecting her with teen role models. A lot of the LGBT community are really anxious about being role models because they're afraid of being labeled as recruiting, LGBT people, which is probably unfounded, but it's there. And so they did an experiment of LGBT adolescents and then a control group of straight adolescents, and they gave them a piece of paper and say, okay, can you just kind of outline your life for the next 50 years? And the straight teens put down high school, college, marriage, kids, all that. Well, the LGBT group, it was blank. They couldn't imagine what their life was going to be like because they figured out they're gay and they had no role models. And they weren't even sure about any support to go to college if they told their parents they were LGBT. And this is obvious because many colleges now have special funds for LGBT students who get disowned when they come out to their parents, because it's not uncommon for parents to withhold support for education when their kid comes out to them. Okay, so now we're going to talk about alcohol, which is very common in our community. And in fact, lesbians often start drinking quite early, as you'll see, including 13% at the age of 12 versus 2% of heterosexual girls. Lesbians often seek treatment through AA, but they also use other sources outside of AA. And of course, we talked about safety of disclosure, which is an issue sometimes. IPV is definitely present in our community, but it's an undefined problem. It's hard to kind of accept with all the other issues going in our community that interpersonal violence is there probably at the same rate as in heterosexual relationships. And I really like Stephanie Hart made a definition particular to lesbian IPV. A pattern of violence, coercive behavior where a lesbian seeks to control the thoughts, beliefs, or conduct of her intimate partner to punish the intimate partner for resisting to her perpetrator's control. This is not just physical domestic violence, it's also emotional domestic violence. And Janice Ristock in Canada did some interesting observations that the perpetrator often is older and more powerful. Sometimes the beginning of the relationship is in a bar where sometimes older lesbians will look out for new lesbians, and then so the just coming out lesbian then gets into a bad relationship, and then she thinks that's how lesbian relationships should be, to have some violence in them. And then the usual issues of perpetration in both the heterosexual, lesbian, and bisexual women's community include intimidation, sexual abuse, physical abuse, minimizing, denying, blaming the abused, and in particular with our community, there's a threat of outing the victim to her employer or family. And these are psychological factors that can happen where verbal threats are used, the person's demeaned in front of friends or relatives or even strangers, and sometimes the symptoms they present to us with are interrupted sleeping and eating habits. This is a hard one. And when we started Line Martin Health Services a long time ago, well, It was probably 33 years ago. I had an argument with a surgery resident in the emergency room about a lesbian with pelvic pain, and we thought, can lesbians get pelvic inflammatory disease or not? We didn't know, so we put the young woman in the hospital. She was fine the next morning. She probably ruptured an ovarian cyst. At that time, I know this is really hard to believe, we did not have computers. So we had these big books called Index Medicus where we looked up things. I looked under L for lesbian, and there were 3 references. One was to testosterone levels, one was to, I don't know, 3-year-old masturbating or something, and something else. So we decided to do a study on sexually transmitted diseases in lesbians because we didn't know. So I recruited my straight OBGYN residents and opened up an evening clinic in the family planning part of San Francisco General, but we covered the sign up whenever we had our clinic, so lesbians would come. And we got 178 sexually active lesbians and studied chlamydia and gonorrhea and all this stuff. And we studied why lesbians didn't go back to their doctors. And a lot of it was that they had birth control pushed on them inappropriately because they weren't out to their doctors, and the doctors had good intention. You're 25, you need this birth control and that birth control, and they get really quiet and they just wouldn't go back because they weren't ever asked about their relationships and what they really needed. But lesbians do need birth control because of self-identified lesbians, 15% are sexually active. So those 15% need birth control. And how do you bring that up in a sensitive way? We know from national studies that actually unintended pregnancies are higher in lesbian female youth. I mean, it sounds like it should be the opposite, right? But they're actually higher. It keeps showing up. And the reason is risk-taking, that a lot of lesbians are having, sex with their gay male friends, and there's alcohol involved and not great judgment. But there are more unintended pregnancies. Or they don't listen when they talk about sex lessons in gym class because they think they don't apply to them because they are identified as lesbian. So we need more research into that. So figure out a way to say that sensitively so you don't turn off your lesbian client to coming back to see you. But you do say, I use neutral leaders like, some young women like yourself identify as lesbian, occasionally have sex with men. I just want to be sure, you don't have an unintended pregnancy. Do you want to talk about condom use, or do you want to go on the pill just in case? And so there are ways to try to do that, but you also want to acknowledge who they are and be really sensitive. About 50% of lesbians or more have actually had oral contraceptives over the course of their lifetimes for either, changes of bisexuality when they needed birth control, or when they were treated for menstrual cramps or endometriosis. And we know that even being on birth control pills for 6 months can decrease ovarian cancer later. Now, there hasn't ever been a study about this, but it's just there are some advantages to birth control pills for women's health overall. And then I'm sure you probably know about emergency contraception that in California is available over the counter now. So if someone has unintended intercourse, they can, within 72 hours, just go to the pharmacist and say, hey, I need like the morning after pill, or Plan B is what it really is called. There are more and more babies being born in the LGBT community, and there's so much rapid change here from the Association of Sexual Reproductive Medicine specialists saying all people should have access to like in vitro fertilization, because many fertility clinics only treated married folks for many, many years. And in fact, it was here in Southern California that a lesbian couple sued under a California statute when they were denied insemination services by their HMO, and went up to the California Supreme Court, and it was decided that offering infertility services is actually a business and you can't discriminate, and they actually won. It took them 5 years. They went elsewhere and had a couple of kids in the meantime. But it's important to ask all of your patients, what are your plans on having children? Because the other thing is lesbians are having children really at a later age, and that's full of misconceptions. It's harder to get pregnant when you're 40. There's a lot more miscarriages. There's a lot more birth defects. And so anyone who is like 30, 35 should think about, do I want children, and how am I going to figure this out now? And let's go, get on vitamins 3 months ahead of time so the birth defects are decreased, things like that. But lesbians, because if they're sexually active with women only, it's not going to kind of happen by accident, which 50% of pregnancies in our country are unintended. They need a little bit of planning about, are they going to have a known donor? Are they going to have an unknown donor through a sperm bank. How are they going to do this? Are they single? Are they in a couple? Do they need to go to therapy to talk about a baby if their partner has never thought about becoming a co-parent? A lot of considerations, but it's important to us to be non-judgmental, to be excited. We now finally have incredible data showing that children of LGBT parents are the same, or actually are on some meta-analyses, which is kind of a combination of research, shows them to be a little bit more androgynous, a little bit more nurturing, and a little bit more open than children raised by heterosexual parents. So the data is there. It's just not accepted by many people and not known by, like, say, the parents of the lesbian who's planning to get pregnant. And as a health professional, you can, when the grandmother comes in to look at the baby on the ultrasound with her daughter, and you can say, oh, isn't it great? And be really a positive part of that team. So this next concept is a little strange to think about and also expensive, and most lesbians can't afford it, but there is more and more of it happening, which is something called co-maternity or co-IVF, where you have a lesbian couple, and so one donates the genetic material, the egg, it's put in a petri dish mixed with the sperm, and then the embryo is put into her partner, so that they each have a biologic role in the conception. We haven't figured out yet how to put two eggs together. Maybe 10, 15 years. But in the meantime, there's a small research study that showed there's a little less competition between the moms raising a child when they each participate in the biologic process. We also know that we can induce lactation in women who are adopting and in lesbian co-parents, and we have protocols for this. And so it's important that you make sure that when you have a lesbian couple who have a pregnancy, that at least they know that's available. Not many, in my experience, will take you up on it because it involves hormones and lots of pumping, etc. So right now, this is old data. About 16% of lesbians have given birth, but many lesbians become parents by foster care or adoption, co-parenting, and some have unexpected pregnancies when they have sex with men. I mentioned how important vitamins are 3 months ahead. It definitely decreases the risk of spina bifida, which is a birth defect in the back. It may decrease the risk of congenital heart disease. And it's important to also, every woman now, it's recommended to have at least one HIV test during her lifetime. You also want to make sure her MMR or her rubella vaccine is up to date before she gets pregnant to make sure she has antibodies. And now some of my patients go get this huge genetic screening with these companies and come up with all these carrier states, and they test their partner for the carrier states, and they come into the gent counselor all before they get pregnant, because the whole genomics field is kind of exploding. And so keeping up with that's important. It's interesting that the Williams Institute, which I have the greatest respect for, thank you, UCLA, has provided incredible information for us educators to talk about health, and they do a lot of work with law also and LGBT issues. They describe these are the cities where the most children are being raised with LGBT couples and single parents, which aren't exactly what you would think because they're all in many conservative areas. And so these parents not only are having to often be the first in the preschool class to be LGBT parents and be leaders, but they can use a lot of support. Before we had same-sex marriage, lesbian and gay people went to incredible extremes to protect the rights of the non-biological parent. However, in California, we've had a case that got to the Supreme Court that also guarantees the intended parent's rights, even if they split up and the non-bio parent was not married. So very complicated. NCLR, National Center for Lesbian Rights, has been a leader in this. So often when my patients are thinking about a pregnancy, I say, have you seen an attorney? However, some people have been very nervous about having to get married so many times, and is this time, is it going to be overturned? So they actually will co-adopt the child their partner biologically has, just to assure their rights if gay marriage gets overturned. So Elizabeth Losada did a really great project at Kaiser Oakland. Kaiser insures in Northern California a third of the population, and there were just very disparate resources that you had to go to if you're interested in becoming a parent. So she was able to mobilize these for a health system. And for those of you in health systems, it would be really helpful to advocate for one-stop shopping for, LGBT folks who are interested in conceiving and having a child, to find out what their policies are, to help them access the important resources and not have to reinvent the wheel each time. And we talked about outcomes of children of lesbian couples. The one reason it's been researched so much is because many divorces in the 1940s and 1950s had to do with people coming out as adults after having heterosexual marriages. And routinely, the person who came out would lose all of their rights to see their children. And so the research started way back then to prove to the courts that LGBT parents are competent. And so we've had more and more of this research happen. Now, it's not without issues for children of lesbian parents to feel stigma when they're teenagers, and sometimes they don't want to bring their friends home, et cetera, et cetera. But in other settings, sometimes it's cool to have lesbian moms. And so it varies. But pediatricians, et cetera, just need to be sensitive about some of the issues that children raised by LGBT people have. And there is a support group for these young people called Collage. It's Children of Lesbian Gays, and it's in most major cities, and it's very, very helpful. And Annette Gartrell, who has been a pioneer in following a cohort of same-sex moms for now 25 years, has found that those who were conceived by donors versus known donors versus unknown donors have equal behavior issues and equal academic successes. So that's important information for lesbians who are thinking, well, should I use a friend to donate sperm, or should I use an unknown donor? That the outcomes, the satisfaction by the lesbian mothers are the same, and the outcomes of the children are the same. And these are just some families. When I do this talk to my medical students, they always want to know, well, how do I not make the faux pas of a lesbian bringing in a toddler with two moms? I don't want to say, who is the real mom? Okay, because that happens sometimes. So here are just some examples of lesbian families, and these are two women physicians who had Max by IVF, because Linda, who is on your left, had repetitive miscarriages due to fibroids. So they took her egg and mixed it with sperm, unknown donor, and then Leslie carried 2 pregnancies, and there was 2 for 1 on the second pregnancy with twins, which happens more with in vitro fertilization. And they're now all in high school and having a blast. It's a family from the Midwest. It's a biracial family by adoption, and these kids, Abby and Isaac, were raised in the Jewish faith, and the grandmother is very involved, and they did tag parenting. So one stayed home during the morning and one stayed home in the afternoon the first 5 years of the kid's life. You'll see lesbians and gay men have a lot of interesting sociologic inventions, since there's not the usual gender roles that have been established in the heterosexual community. So that's something they can contribute. This is a family of 2 moms and 2 dads, and the moms are like in academics, and so they were able to travel and keep up with high-level careers, because Daniel was at their house 60% time and with his dad's 40% time. And finally here, Terry and Mary, the only profiled lesbians. They're both gym teachers, and they came to our practice with Mary first, who was on your left, being pregnant. And Terry's mother is in Orange County, and Terry's mother said, I just don't want to be a grandmother. I know your partner's pregnant and having a baby, but I'll come visit once or twice, maybe. And then Terry had a baby using the same donor, so they're half siblings. This is very common. And when Terry had a baby, her mother totally disowned her. And so Terry, even though it's her blood grandchild, so about 3% of grandparents will totally reject their grandchildren of their LGBT children. And only a third of them actually come out to their friends that they actually have a lesbian daughter. So it's very complicated. And so, you may see a 55-year-old woman who having some depression. She may mention, my daughter, is pregnant. She's a lesbian, and I feel so bad for the child. So educate her. In fact, my own mother, when I was pregnant with my first child, my partner flew her out to my baby shower as a surprise, and she was talking about telling her hairdresser that the child's last name is going to be Robertson, and that she was conceived by artificial insemination. Now, my mother's very Irish Catholic, and we never could have Ms. Magazine in the house. And I said, Mom, I can't believe you said the words artificial insemination to your hairdresser. And she said, yes, thought it was important. She knew it wasn't a one night stand. So you just never know. And anyway, so now we're going to midlife. Okay, midlife. Breast cancer is maybe a little more common in lesbians, but all women are at risk for breast cancer. Lesbians have a few more risk factors, probably because more smokers, which I consider one of the biggest public health problems in our community. Many of them haven't had children, which protects from breast cancer, but really only if you're young, like less than 30. And many of them, therefore, haven't breastfed. Many have had previous breast biopsies, which is a risk factor. BMI or obesity is more frequent in our community, which is associated with breast cancer. And many are drinking or have had alcohol heavy use. So it's mixed as to whether lesbians get mammograms on time. The whole mammogram question has been thrown into the air again. No one knows exactly the right schedule to be on, but we do know clinical breast exams can pick up breast cancers, and lesbians see doctors and nurse practitioners less often, so it's important to screen them with a clinical breast exam. Often breast support groups are hard for lesbians because they're usually heterosexual. It's all focused on the loss of the breast for the male partner. And so in some urban areas, there are support groups for lesbian cancer partners of cancer survivors. So end of life is very, very poorly studied, but in the small studies that have happened, it's shown that lesbians have more positive beliefs about hospice and alternative medical care than heterosexual women, and are more practical in looking at treatment when there's incurable disease. However, the decision to enter hospice for lesbians is very complicated, especially if they're not out or they have children. Nursing home discrimination has been well documented in our community. It's poor treatment. If you come out, a lot of people go back into the closet when they go into nursing homes, and that's really bad. Often nursing homes, they have rooms for consensual sex activities that they're restricted for LGBT people. And I have this one friend who went to visit her friend who was in a nursing home, and she happened to come in when they're trying to get her dressed, and she was just fighting them, and the friend said, why are you putting a dress on her? She's never had a dress on in her whole life. And so just knowing individually about people and individualizing their care is so important. And a lot of communities are now trying to have aging in place, like villages in San Francisco. I'm sure in LA you have similar movements so that LGBT people can avoid nursing homes and discrimination and, have services in their home. If someone is not open about having a lifelong partner, when the partner dies, it can be very complicated grieving that is more likely to go into depression because they can't openly acknowledge that grief. And a lot of LGBT people are not out. We think they are because here we are at this conference, but some of them are hidden, including we started a lesbian physician conference 33 years ago. It's an annual meeting, and I have a donor to our Lesbian Health Fund, which does pilot projects for lesbian health, which has been very successful, and then the researcher goes on to get NIH funding. And she gives me cash. She doesn't want her name on that money. She's an orthopedic surgeon. And so don't assume that education or anything equals comfort with being out. So this is a summary from my point of view on best practices in lesbian health. Being supportive. I always interview people for our front desk. They think I'm crazy because I'm totally overextended. But to me, that is the face of your practice or people at your front desk. And if they make a disparaging comment, you're not going to get that patient back for their health care. So my question to the interviewees is, what kind of experience have you had with LGBT health? In fact, I use it when I do admissions committee work for the medical school. And I had one young woman who went to UC Santa Barbara and said, what is LGBT? And so you'll be interested by opening that question. Someone say, oh, I have a gay brother, and, I'm really excited about, helping in a medical office and making it more diverse and inclusive. Or you might have someone who says, well, it kind of creeps me out. I mean, I like taking care of patients, but, patients who are, and sometimes they'll put them in categories like drug seeking or gay or whatever. And that's not the person you want to have at your front desk, okay? Or you want to educate them. So anyway, it's really important. And you want to do appropriate screening. Lesbians do need pap smears. They do get cervical cancer. We do have disparities in the HPV vaccine that's being given. Only 8% of lesbians have had HPV vaccine versus like 16% of all people. Now, that's still too low. We all need to be really encouraging people to consider the HPV vaccine. We need to talk about family planning, both for prevention of unintended pregnancy and what are your plans for having children, and not have someone who's 45 and realize that she can't use her own eggs, she's going to have a complicated pregnancy, that we need to have people understand the statistics and that the biological clock does matter. And then we want to make sure everybody has power of healthcare decision papers ready. All of us need to be advocates for our vulnerable population patients. And we cannot change healthcare without our allies. We're a very tiny minority of LGBT health professionals. We need our allies. And they need us to help with their causes and inclusivity for healthcare. So don't silo yourselves off, be inclusive. So go home after this conference, go to the office and check your intake forms and take a look and see what you need to do to change them. Educate your staff, provide lots of inclusive materials in your waiting room and in your educational arena, and ask sensitively about sexual orientation. Also be aware that if you have LGBT colleagues, that they are often discriminated against themselves, and make an effort to, be a professional friend with them. So thank you very much. I'm thrilled to be here. Oh, go ahead. Yeah.
So I've been asked, first of all, if you have a seat beside you, please raise your hand. We've got some people standing in the back. And so those of you who are in the back, please come up, take a seat. We want to welcome you. I also want to say that we got a lot of great questions, including some very detailed questions, and we can't get to them all right now, but please feel free during the breaks or at lunch to approach the speakers. So I'm going to ask you 3 questions. The first was, why do lesbians need a pap test if it's someone who's never had sex with a man?
Great question. So we don't know enough about the transmission of HPV, but we have had HPV documented in women who've never had sex. Did they acquire it perinatally, or what's going on? We don't know. But the good thing is that unless you have like symptoms of bleeding or whatever, we're not doing pelvic exams anymore until women are 21. Okay? And so that's, I know, we think about all those unnecessary pelvics we had and the trauma, because lesbians do get traumatized, especially if they're not having penetrative sex. Only about 50% of lesbians use dildos for sexual practices, and using a reasonable size speculum is often very traumatic for lesbians, so you have to be gentle.
Thanks very much. Now, the second question we had is, can you discuss the unique risks of the lesbian and bisexual population to antenatal and postpartum mental health issues?
So we need research in this area, but my experience is because lesbians often have more depression history, they're going to have more postpartum depression. So they may need special support during pregnancy, and a powerful trigger in the postpartum period is fatigue, and sometimes the families don't necessarily come through all the time for lesbians as they do for heterosexual women. So just having doulas, postpartum doulas, and friends who understand what having kids is like. Because the other thing, when lesbians have kids, they often lose a lot of their lesbian friends who don't have kids because it's so intense and encompassing. So they need to name lots of godparents informally to help them as part of their postpartum team. We're trying to name the postpartum team now for all of our patients who deliver, so making sure that happens. The antepartum issues have to do with chronic high blood pressure, for instance, because of obesity in our community. There's more hypertension, there's more diabetes, and often they're older. So those are kind of 3 major issues, and we do need to research it, but that's been my experience.
And then the third question is, why now do we use the term interpersonal violence instead of the term domestic violence, which is, I think, what you and I learned in medical school?
Kind of domestic is the domicile in the home, and we know that not all LGBT people live with their partner, so that's why it's been broadened to interpersonal violence. I'm sure the term will change as the generations change, but just this can also be, daughter adult violence. I mean, it encompasses a lot of different kind of violences, but right now, IPV. I will be here during the break. I would love to talk with you and hear other questions, and also just brainstorm, because we're still learning and we need you to help us learn and know where we need to do the next research clinically. So thank you so much for coming. You're going to make a big difference.